started, ma'am.
Good evening to you all. The topic for today's talk by Abha ma'am is on clinical utility of pre-implantation genetic testing in general obstetrics and IVF. It is a very important topic in today's time for all clinicians, both obstetricians and infertility specialists. So over to you, ma'am.
Thank you, Bhavani. Yeah, I thought that, I should bring a topic which is of importance to the general obstetricians. They encounter such cases every day in their life, and at least they would know whom to refer for pre-implantation genetic testing in general practice. So, what is pre-implantation genetic testing? As the word goes, it is a technique that involves testing of in vitro fertilized embryos to identify genetic or chromosomal disorders. So these could be monogenic diseases like thalassemia, or they could be chromosomal disorders like Robertsonian translocations. So in which conditions do we do a pre-implantation genetic testing? PGT-M and PGT-SR. As the word goes, M is for monogenic disorders, SR is for structural rearrangements. And this was earlier known as PGD. Now that terminology has gone away for diagnosis of a disease. And PGTA is for aneuploidy, just to see if the chromosomal numbers are normal and there is no monosomy, trisomy, anything like that. And this was earlier known as pre-implantation genetic screening. But we have taken away these two nomenclatures and we are at one nomenclature, pre-implantation genetic testing, whether it is M, SR, or A. Now, M and SR is for fertile couples presenting to all obstetricians with inheritable genetic disease or with repeated miscarriages. Like someone comes, you get to know that this child has muscular dystrophy, or this child is thalassemia major. Then we go back testing the father, mother, and we find, oh, this was autosomal recessive disease, or the other one was a dominant. So these come from the parents and they lead to genetic diseases which are either incompatible with life or very difficult to manage all across life. Or such patients also present with repeated miscarriages. So wherever you have two or more miscarriages, please test the parents' karyotype to see structural balanced translocations are there or not. PGTA is specially for clinicians who practice IVF, and this is for infertile couples undergoing IVF. And here, if you want to reduce the time to pregnancy, then you can select the numerically normal embryo to reduce the miscarriage rate and increase the chance of live birth and reduce the time to pregnancy. So we'll come to all these three. First thing is, when do you do PGT-M for monogenic disorders? Either it has to be a single gene disorder. Only single gene disorders can be identified and a gene probe can be developed for them and the embryos can be tested. Then a second group of disorders which are rarely seen, but you might come across this sometimes, a mitochondrial disorder. And the last one is HLA typing. This is not to prevent a disease, but the indication for this is very different. I'll tell you when I come to detailing all the three. So single gene disorders are, we must know the causative gene mutation, because if you don't know what is the causative gene, what will you test? Like if you take blood and you don't know what are you testing for, you'll say, iska test kar dijiye kya? You'll say it is blood sugar or it is LFT or KFT. Same way, we must be able to identify the genetic mutation in one of the parents or both the parents or grandparents. And we must know whether it is recessive or dominant. Now, if it is recessive, then 2 copies of the abnormal gene will cause disease. Otherwise, it will only be a carrier status. So a copy has to come from the father, another copy from the mother, and then there will be a true autosomal recessive disorder in the child. If only one copy goes from one parent to a child, they would be carriers. And if their partner has the same gene in future, then they can also make a child with the disorder. Now, when only one abnormal gene is needed to produce the disease, it is a dominant hereditary disorder. It is autosomal or sex-linked, but it is a dominant hereditary disorder. Now, either we have autosomes on which these genes are there, or we have the X chromosome on which genetic mutations happen. They don't happen on the Y chromosome. So Y is out of everything. So one abnormal gene needed means that only father or mother is diseased, and if that gene comes to the child will get disease. There is no carrier status here. It is either a normal child or a diseased child, whereas autosomal recessive will have a carrier status, a normal status, and a dominant, a child with the disorder. Now, single gene disorders, again, I emphasize we must, by genetic counseling, find out the causative gene mutation. A genetist has to be involved in this. They can test the parents and then say that, yes, this is coming from both the parents. So autosomal recessive, both parents are carriers. So what happens? The risk of disease would be 25%. Free of disease would be 25%, and 50% would be carriers. If you take, like, say, 100 embryos made, then this should be the distribution, that two diseased ones come together, it makes a disease. Two normal ones come together, they make absolutely free of disease, and the rest are all carriers in which one parent's gene comes. This is like cystic fibrosis, hereditary hemoglobinopathies such as thalassemia. Then we have a autosomal dominant. Like I told you, one parent has the disease. Disease risk is 50% and disease free is 50%. Myotonic dystrophy, neurofibromatosis, Huntington's disease, they all come in this. And believe me, we have done testing for all these diseases and many more which are not listed over here, which keep coming to us, and they are all sent by obstetricians. They get the genetic testing done, they identify the dominant or the recessive gene, and then the patients are referred, and then we refer them to the genetic lab to see, can you identify this gene? When they do a testing, develop a probe, they write back to us, yes, we can. That is when we enroll these patients for IVF. They don't need IVF otherwise. Then X-linked recessive conditions, and there are also X-linked dominant conditions. Now, X-linked recessive condition, disease in males and females are carriers. Why? Because if it is linked with X, that X goes in the male. So the male would have the disease, but father cannot pass S-linked traits to sons, because what will they pass to sons? Only the Y chromosome. They don't pass the X. Only mothers pass the X to their sons to be diseased, or the fathers will pass the Y chromosome to the son, so he cannot be diseased. X can make the daughter a carrier again. So Duchenne's muscular dystrophy, hemophilia, red-green color blindness all come into X-linked recessive conditions. Now, there are also X-linked dominant conditions. Now, recessive, two genes together would make it, dominant one alone. So affected males transmit mutant allele to female, not to male offspring. So they have a dominant gene on their X, right? If that X goes from the male, it will always make a female, because from the mother another X will come. So the mutant gene will go to the female, not to the male offspring. Affected females transmit to 50% males and 50% of females with that X. So vitamin D resistant rickets, Charcot-Marie-Tooth disease, porphyria, fragile X syndrome, and we have done IVF in Charcot-Marie-Tooth disease, in porphyria. We've done it in red-green color blindness. We've done it in hemophilia, Duchenne's muscular dystrophy, thalassemia, and cystic fibrosis, and in myotonic dystrophy. So these are all cases which keep being referred to us from general obstetricians only. What are mitochondrial disorders? I wanted to bring this to your notice, because mitochondria's own DNA is made of 37 genes. So mitochondria is what is outside in the cytoplasm. And this mitochondria has DNA which has 37 genes. See, there are millions and millions of genes in the nucleus of the egg. But in the cytoplasm, there is only mitochondria. It has genes which is only passed by mother to child, because all mitochondria in child comes from ooplasm. This is separate from the genes of the cell nucleus. So this ooplasm will go from the mother to son and daughter both, then again to son and daughter both. So, but the daughter will be able to pass it, not the son, because the sperm has only the nucleus, doesn't have the cytoplasm around it. Whereas the daughter will have the whole ooplasm, which will carry this mitochondria with it and the 37 genes which are in it. Now, over the years, over generations and generations, normal women have identical homoplasmic mitochondrial copies, but affected people, what happens that the genes start mutating with time and with generations, like down the line 100 generations, the mitochondrial genes get mutated, and there is a mixture of normal and mutated genes. So threshold level of mutation of mitochondrial DNA that causes disease is 60 to 90%. So much should be the mutation that they can cause a disease, 60 to 90%. Less than that, it will still be homoplasmic and it will not cause the disease. So PGTM for monogenic disorders allows selection of embryos with a mitochondrial pathogenic variant load below the threshold of clinical expression. And what are the diseases which have come through mitochondrial gene transmission? Leber's hereditary optic neuropathy and Kern-Sayre syndrome. These are all in literature, and you will find that these diseases come up and people have replaced mitochondria to be able to get rid of these diseases. Then the last is HLA typing. This is also done for monogenic disorders, but it is not done to get a disease-free embryo. HLA typing of an embryo is undertaken not to prevent disease in the tested child. It is for treatment of an affected sibling present with a hemopoietic disorder. So if one child has thalassemia major, parents want to have another child through IVF where the embryo can be tested and it should be either disease-free or a carrier. And they also do HLA typing with the existing child's genetic makeup. And if this HLA matches of the embryo and of the existing child, then it is for treatment of an affected sibling present with a hemopoietic disorder. It selects HLA compatibility with an affected sibling requiring bone marrow transplant. However, a lot of ethical issues surround this testing, and I mean, human rights people have gone a long way to say that this should not be done because the child cannot speak, and we cannot just use another child which is born and cannot contradict, use his bone marrow to help the other sibling to survive, and the child cannot consent to it. So there's a lot of controversy, but still it is not disallowed. So people do come for HLA typing. But remember that if we have 10 embryos, HLA typing may be there for just one embryo, and that embryo could be the affected one or the carrier or the normal one. So PGT SR structural rearrangement. I come to the second indication, which is often encountered by obstetricians. How do these patients present? How do we find out that there is a structural rearrangement? Karyotyping of both partners. And whom do we karyotype for? If they have history of repeated pregnancy losses or recurrent implantation failure in IVF, we still do a karyotype if we find we are transplanting a very nice embryo, yet it is not implanting. And it is also done for abnormal babies to identify balanced translocation. Different type of balanced translocations are associated with abnormalities, IUGR, etc., and hence karyotyping is done for both partners. 60% of such couples have a risk of progeny with unbalanced translocation, leading to pregnancy failures or losses. I'll explain this in a minute. How does it happen? PGT-SR for structural chromosomal rearrangement in the embryos from parents with parents will always have balanced translocation. That is why they've become normal human beings. A man, woman got married and are producing children. But one piece of chromosome from any one out of the paired chromosomes can break and go and attach on another chromosome. Now here, the broken and the attached piece make a complete genetic picture, and hence there is no genetic imbalance. But when these chromosomes separate and neither the lesser one or the longer one goes into the child, it becomes imbalanced. And that child cannot survive with an extra chromosome or a reduced chromosomal segment. So if we can test and we can see which of the embryos have um, balanced translocation and which embryos have an imbalanced translocation. So the imbalanced ones can be separated out, not transferred into the woman who has had multiple miscarriages before, to prevent further miscarriage. Two most common translocations are reciprocal or Robertsonian translocation. These are the commonest of all translocations. In reciprocal, two different chromosomes exchange segments with each other. In Robertsonian, an entire chromosome attaches to other at the centromere. So an entire chromosome, one segment, the P or Q, will get deleted and go and attach to a centromere. Last comes PGTA, aneuploidy check. This is mainly for women undergoing IVF. And we've tried to find out that which segment of women will help by doing aneuploidy check in these chromosomes. Because we do analysis of chromosome copy number. Here we just see that the copy number is okay. There's no extra chromosome with any pair of chromosome out of the 1 to 23 or the sex chromosomes. And before transfer, to reduce early miscarriages, increase the live birth rate, reduce time to pregnancy. And what are the indications for which aneuploidy was being searched for? Yeah, I will tell you in a minute. After a comprehensive review, ASRM published a practice guideline 2018 concluding that there is insufficient evidence to recommend the routine use of PGTA in all IVF patients. They said don't do it for all IVF patients. Whom is it important? Subset of patients who may benefit from PGTA. One is advanced maternal age. And when we say advanced maternal age, it is women over 37. Recurrent implantation failure also, we thought that maybe it might help. And maybe these are abnormal embryos which do not implant. Recurrent pregnancy loss also, but unless the recurrent pregnancy loss is associated with a translocation defect in the chromosome, they have found that it doesn't affect the implantation. Severe male factor, and those who want only elective single embryo transfer, they want all the embryos to be tested so that only the normal one, single embryo, can be transferred. However, after extensive research over the years, PGTA came into practice from 2010 and 11 when Scott and his whole team started doing PGTA, and they recommended this very strongly. After that, from now, we have moved almost 12 years. But it has been found that the only subset of patients who benefit from PGTA is advanced maternal age women, not RIF, RPL, male factor, or yes, opting for single embryo transfer with advanced age is a very good option. Now, we all have to understand that 30 to 60% of human embryos have some type of chromosomal abnormality. This increases significantly with advancing age. Now, if you see, chromosomal abnormality is to the tune of 20% here at the age of 29, and how it goes on rising as the age goes up to 44. Percentage of embryos with aneuploidy at the age up to 32, 36 also, the percentage is less than 40% or maybe even less than 30%. But as age goes up, it goes steep and it goes to more than 90% by the age 44. So we understand that at 44 age, if we are making embryos, 90% will be abnormal in the chromosomal aneuploidy screen. So if we make 4 embryos, 90% are abnormal. Maybe out of 4 embryos, 1 is going to be normal. We don't know which one is out of here. So if we go on putting one after the other embryo, we may waste a lot of time. But if we've done an aneuploidy screen, then we can put the embryo which is euploid. But the only thing is that even that euploid embryo will have the same implantation rate of the IVF center where the embryos have been made. If the implantation rate is 30-35%, this embryo will implant 30-35%, even though it is euploid. If the implantation rate is 60-65, it will implant, the chance of pregnancy would be that much only. So we have to remember that what we see on top of the sea level is clinically recognized pregnancies. First, we see miscarriages, first trimester. If the child grows further, then we find Down, Patayu, Edward Turner's, other sex chromosomal disorders, autosomal disorders as IUGR, anomalous baby. And the rest is all below the sea level where there is implantation failure. And these embryos do not implant if they are abnormal. So nature has selected out the abnormal embryos in women so that out of those 30% which are abnormal, most of them will not implant, and very few which will implant will lead to these diseases which I have just enumerated. So this is nature's way of protecting our women from implantation failure. And now who all need to know about PGT? PGTA by IVF specialists, that is IVF failures with high risk of aneuploidy, which is known in advanced age mothers. So we need it when women of advanced age come with repeated failures. Now, PGTM and PGTSR is encountered by all obstetricians. So clinicians need to be well versed with all aspects of patient selection for PGT and to be able to adequately counsel these patients also. So all obstetricians in today's world, if you are practicing modern advanced obstetrics, you need to understand how do you select these patients, how do you identify, how do you move forward, and how you counsel them. So patient selection and counseling, PGTM or SR ensure genetic diagnosis is technically feasible. Thus, a pre-PGT workup is essential by the genetic laboratory conducting the test. So first, your clinical genetist has made a diagnosis that I have done a chromosomal analysis and it is a structural balance translocation, which is there in one of the parent, or I have done the gene finding, and this disease is related to this single gene, which has caused all the disease in the child. After that, again, it has to go to the genetic laboratory who's going to conduct the test. So they have to do a pre-PGT workup, which is quite expensive in some diseases, but generally would cost up to 1 lakh of rupees. So cost involved depends on type of PGT, number of embryos tested, and the cost of IVF also has to go inside into it. And therefore, and women who have low ovarian reserve need multiple cycles for pooling of embryos to find genetically normal embryos. And if we're looking for thalassemia and we get 3 embryos and we find all 3 have either major or carrier, we do transfer, but have major thalassemia, or we're looking for HLA typing, we may have to collect 10, 12 embryos also, which are genetically normal and they serve our purpose also. Then financial constraints or low ovarian reserve. These two things, women cannot, they cannot go through IVF if there are financial constraints, or the ovarian reserve is low, then they have to go through multiple cycles. In that case, women can opt for natural conception because these are women who are getting pregnant normally. But for them, chorionic villus sampling or amniocentesis is a must to identify a diseased baby or a carrier baby or a risk-free baby. Because, but then the only negative part is that suppose this baby turns out to be abnormal and you need to abort the child. The risk of an added miscarriage may increase overall risk of abortion in subsequent pregnancy, even in absence of the genetic disorder in the embryo. Now, what happens that we know that up to 2 pregnancy losses, the risk of abortion stays about 18 to 20%. The moment there are 3 losses, it goes up to 30-35%, and after 4 losses, it is more than 40%. So as the number of abortions go up, it is uterus itself, it gets so scarred that it leads to an abortion also of a normal child. So we have to prevent that from happening. It is better to sort of not let the number of abortions go over 3 and 4, because then the uterus becomes more susceptible to abortion apart from the risk factor which is leading to abortion of the embryo. So, and another thing which we need to exclude, so if there are financial constraints or low ovarian reserve, please opt for natural conception because that is free of cost. CVS or amniocentesis will cost, but it is a fraction of what IVF and PGT will cost. But just see that the woman has not had too many abortions earlier. Now, exclude women with serious health concerns also due to genetic disorder for which PGT is requested. Like women who have cystic fibrosis, they have so much of respiratory problems that when they go through pregnancy, it is very, very difficult for the obstetrician to take them across pregnancy. Sickle cell anemia, Huntington's disease, these become incompatible with a normal pregnancy. The woman is not able to carry a pregnancy very happily. So please do not do PGT for such women, or in today's world, arrange a surrogacy um, option of surrogacy for such women because they cannot carry the pregnancy forward. Again, you have to see whether she will be able to look after her child or not. Does her health condition allow her to look after? If that is also not there, then do not advise surrogacy to such women because these children need maternal care as much as they need uh, paternal care. And then we also have to remember the possible, this is a new technology. I told you that we just started in 2010, 11, 12. So possibility of a misdiagnosis owing to mosaicism should also be explained, and decision regarding transfer of mosaic embryo should be discussed. There are points, and we do a good genetic counseling with the genetist regarding how much percentage of mosaicism is there. And mosaic embryos do self-correct themselves if that mosaicism is only in the trophoblast for a small segment. But if the mosaicism is there and the percentage is high, then we need to discard those embryos. So this I've taken from the chapter I've written on PGT, when and where to offer, in the book Algorithms for Infertility and Reproductive Medicine. This chapter is with Bhavani Shekhar. And pros and cons of PGTA in patients with advanced stage more than 35 years. This is PGTA. I'm not talking about SR and genetic disease. In that, it is a must. Pros of PGTA is that only advanced age women, it reduces time and number of embryo transfers required to attain a live birth. It reduces miscarriage rate due to high incidence of aneuploidy in advanced age patient. It promotes single embryo transfer, thus reduces risk associated with multiple gestation. And it also helps us clinicians to determine which embryo to transfer on priority. And it also helps to identify and discard aneuploid embryos, which could potentially reduce the burden of excess embryos which are cryopreserved. So we just throw them. What are the cons? It does not increase the chance of live birth amongst women of all age groups. So if we try to do across all women undergoing IVF, it will not increase the live birth rate. It is only for a small segment of women who are of advanced age. It is an expensive procedure and it adds on to the cost of IVF. There is need for increase in resources, as well as it is very labor intensive for the embryology team because they have to first take a biopsy, preserve the DNA, and then freeze all these embryos. Due to technical challenges, there is a small risk that test results may not reflect true embryo status. And some embryos have a mixture of normal abnormal cells, that is mosaicism. This can result in a false positive or false negative PGTA result. And sometimes no embryo may be suitable for biopsy or transfer. So you have to understand, all IVF people have to understand that just giving the option of PGTA is not enough. We need to counsel our patients regarding all the negative things which could happen with PGTA, despite a lot of positive things also coming up. Well, this I've taken from the chapter, so I don't need to repeat it. Now, role of prenatal diagnostic testing after pre-implantation genetic testing. Now, prenatal is when the patient is already pregnant. Now, in all these women, do you do a prenatal diagnostic testing? Listen to me. Prenatal diagnostic testing in PGT-M or SR conceived pregnancies by chorionic villus sampling or amniocentesis should be offered to all patients for confirmation of the PGT result. Because this is still a new test, and there could be a mistake in genetic testing, so this is recommended. But I'm telling you a fact. Maybe 25% of my patients refuse to go through a chorionic villus sampling if everything looks normal. But then these, in SR, if they refuse to go through a chorionic villus sampling, it's all right. But in PGTM, I think it becomes more important because in SR, generally pregnancy losses happen in the first trimester or maybe in the late first trimester. So these pregnancies in any case don't grow well. So you don't need to do a CVS so much. But in PGTM, which are where are monogenic disorders, I think everyone should insist that they should do it just to ensure that the diagnosis was correct and your baby is not suffering from the genetic disease which other siblings or parents may be suffering from. In patients who have undergone PGTA, we don't need to do invasive prenatal testing. Just NIPT or a dual marker is good enough. Prenatal diagnostic testing is not recommended for pregnancies conceived after PGTA unless abnormal findings on 11 to 12-week scan or NIPT indicates high aneuploidy risk. You do a NIPT, it indicates a high aneuploidy risk, or the NT-NB scan is garbar, then you need to do a proper CVS or amniocentesis. And in PGTA conceived pregnancies with mosaic embryo transfer, invasive prenatal diagnostic testing is again mandatory. So where is it mandatory? In all PGTM or PGT SR conceived pregnancies, though PGTM is more and more important. PGTA, you can just do non-invasive prenatal testing, but if it is a mosaic embryo, it is better to do a invasive prenatal diagnostic testing. And in PGTA conceived pregnancies, we do not do invasive testing unless there is an abnormality in NIPT or NT-NB scanning. So critical factors is the IVF laboratory. So please do not take a low type of a thing about a IVF laboratory that any laboratory can do PGTA. It is not for all IVF laboratories. Key performance indicators are fertilization rate, blastocyst formation rate, and I will add another one, the implantation rate also. If the implantation rate is high, it is worthwhile biopsying embryos. But if implantation rate is not 60% but 30%, then how many embryos would you put which you test? Additional culture space required for PGT embryos. Quality of culture conditions will determine aneuploidy and mosaicism rate in embryos, impact of embryo viability post-biopsy, how well it is being taken, and PGT may be counterproductive in poor quality day 3 and day 5 embryos. So if the embryos are poor quality, then generally it is best not to do a diagnosis or take a biopsy from these embryos. So key points, take-home points are clinical indication and utility for PGTM and PGT-SR is firmly established. There is no doubt that these are required. This is a very important requirement unless you want to do a prenatal testing. So to have a non-affected baby, role of PGTA in clinical practice remains to be determined. In a subset of patients, particularly those with advanced maternal age, it may reduce number of embryo transfers, miscarriage rate, and time to live birth. In couples where PGTM or SR are indicated, a pre-PGT workup by the genetic laboratory is essential to determine the feasibility of the procedure. Only then they should be booked for IVF. Prenatal diagnostic testing is essential. The invasive prenatal diagnostic testing is essential for confirmation of PGTM or PGT-SR result. But in patients who have undergone PGTA, a non-invasive prenatal testing only should be offered. So financial counseling is a must in these patients as it is an expensive procedure in addition to the cost of IVF. And in women with low ovarian reserve, need for multiple IVF cycle required and pooling of embryos have to be done. Option of natural conception with prenatal testing should always be discussed with these patients. There is a small risk of false positive, false negative results owing to mosaicism, and it should be explained to patients that despite all this, so what is the summary? PGTM will eliminate increased risk of specific single gene disorder from family. PGTSR will stop miscarriages due to heritable balanced translocations and may remove the transmission of imbalanced translocation by scientific intervention. This is a typing mistake. It is imbalanced. PGTA with advanced maternal age will shorten time to live birth by eliminating time wasted. So less reserve, less embryos, we need to repeat cycles. and we reduce the recurrent implantation failure due to embryo aneuploidy. If it is happening due to embryo aneuploidy, we will reduce. And every miscarriage which happens in IVF takes away 6 to 12 months of the patient's time, to recover from the first, have the miscarriage, recover from the miscarriage, the psychological trauma. So a lot of time is wasted when miscarriages happen. So we have to stop them, especially in PGT-SR and by PGT-A. And then our gazette about the ART bill, which was published in December 20, on 20th December 2021, also said that ensure that pre-implantation genetic testing shall be used to screen the human embryo for known pre-existing heritable or genetic diseases and whenever medically indicated. So this will encompass all PGTM, PGTSR, and PGTA. Ensure that no pre-implantation genetic testing shall be done for sex selection for non-medical reasons or selection of, now here also they've written sex selection for non-medical reasons. If there is a medical reason that all the boys are being affected and the girl is safe, there also they don't tell us the sex, they just say this is affected, this is not affected. We have to understand that, it could be, since they are saying it is not affected, it has to be a girl and not a boy. And we cannot do PGTA for non-medical reasons or selection of particular traits due to personal preferences of the prospective parents, or to alter the genetic constitution of an embryo. All that which is said as designer babies cannot be done. So having said that, thank you very much for joining me on 15th August. I wish you all a very happy Independence Day, but I feel very sad on what happened on the 9th of August in Kolkata with one of my younger colleagues. So Independence Day is like a slap on our face, that look at those martyrs who gave their lives to get independence, and yet we have so little safety for our young girls, whether they are doctors or non-doctors today, in today's world. And we all have to join hands to fight this. We cannot change monsters in the society. They will always happen, but we can learn to defend ourselves. Krishna won't come like he came for Draupadi. We need to have our Krishna with us. We need something for self-protection. Every girl should carry some self-protection thing. But how and where, I mean, on roads you can carry, if you're traveling in a taxi or bus, you can carry. But in your hospital where you're doing a duty also, I think the time is coming where all girls should be carrying some type of weapon, whether it is pepper or chilies or a knife with them, to prevent such type of brutality happening to them. Thank you very much.
Ma'am, good evening. Nisha here, Dr. Nisha Bhatnagar.
Yeah,
Ma'am,
yeah.
it was very nice talk and thank you so much for enlightening us. Ma'am, I always have this confusion whenever we are going for PGTM. We do a pre-PGT workup, and in the pre-PGT workup, sometimes they ask even the grandparent sample.
Yes.
So, ma'am, what is the importance of grandparent sample in that?
It is
Because
very important because, some heritable diseases, when they come into the mother or father, or you find a carrier status, then you have to look into the grandparents, or you don't find a carrier status, you have to look into the parents, grandparents' blood also. That is the carrier status coming from there. And wo rakha hua hai, Arvind is there then, let's say.
बट मैम ये तो जेनेटिक अगर है तो ऑब्वियसली आ ही रहा है ना वहां से, तो व्हाई डू वी नीड देयर सैंपल? बिकॉज पेरेंट्स का तो सैंपल है ही हमारे पास,
So if
पेरेंट्स से आए.
it is just a monogenic disorder, they have to develop a probe and they have to see whether it is just one gene which is there in the parent and his parents or her parents, or it is multiple genes. If it is multiple genes, we will go wrong on the diagnosis, Nisha. So
Okay.
that is why it is the They don't ask for all grandparents, but they ask for some grandparents' blood.
No, ma'am, they say both mother and father के दोनों के
No,
parents
अगर
का
alive नहीं होते हैं, कोई नहीं मांगते
हाँ
हैं.
alive नहीं होते तो बात अलग है,
So,
but if they are
और
alive,
भी, if they are not available, not alive, they leave it. But just to get a better hold on the diagnosis, that they don't go wrong on a monogenic disorder, is it a polygenic disorder? उसके लिए वो लोग मांगते हैं. Bhavani, you can explain this?
yeah, Dr. Bhavani, please.
Yes, ma'am, I agree. Usually they ask for blood sample of all grandparents, and that is just to check whether one gene is involved or multiple genes are involved.
Yes. Because if
Okay.
multiple genes are involved, Nisha, they will go wrong on the diagnosis. They use just one probe per person. When it is very specifically written that it is monogenic disorders, not for polygenic disorders.
Okay. बट मैम हमें तो पता ही है ना कि ये मोनोजेनिक है कि पॉलीजेनिक है, जो
नहीं
डिजीज
नहीं,
कॉजिंग है.
ये जेनेटिस्ट बोलता है, तुम जेनेटिस्ट की रिपोर्ट्स पढ़ो एंड दे से वी थिंक इट कुड बी दिस बट दीज आर अदर genes which are associated which may
अच्छा.
not be. So if you
Okay.
read the reports na, it is there. So
Okay.
only if they
Hello.
are alive or they are in matlab they can come and give a sample or their sample can be obtained, then only they insist. If they cannot or they are not alive, they don't insist.
Yeah.
They go on the parental blood sample only.
Okay.
Hello.
Thank you, ma'am.
Good evening, madam.
Good evening.
Myself, Dr. Mahapatra from Odisha, madam.
Yes, Dr. Mahapatra.
Madam, after 35 years, can we do PGT for the embryo or 40 years? Any age is there?
Yeah, it is normally it is 37, but over 35 also you can do PGTA for for embryos. But you must
Aneuploidy.
have a very good embryologist who can take a safe biopsy, not damage the embryo. Also is able to isolate the DNA, because a lot of time you get reports that not the DNA was not there. So DNA should be isolated, tubed well, and the embryo has to be cryo preserved.
Okay, after 35, according to ART law, we can do.
According to ART law, you can do it in any embryo if you're looking for a diseased embryo only, not for sex selection.
No, routinely 35 years, she
We
had.
do it routinely after 37, but you can do 35 also.
Okay, no. What other license we need for that? That invasive license according to PCPNDT or any other thing is there?
PCPNDT. Here you need PCPNDT and ART. Now every IVF clinic which has IVF center requires ART license, and every IVF clinic will require a PCPNDT license.
But at ART2 clinic, it is not that they are giving us PG2 license, PGTA license. No, they are giving to us to do ART2 procedure.
No, it is the ART clinic. If you acquire a IVF license and you have a PCPNDT license, then you can do PGT.
But if we have PCPNDT without invasive license, can we do? We have to do mandatorily invasive. In PCPNDT, two types are there. One is
no, you can do everything. It is just PGT diagnosis. All the embryo is invasive. Now there are newer methods of non-invasive diagnosis, but those are not very robust, and they don't give you, they are still not used in clinical practice. They are only used in research settings where you keep comparing that if you've done an invasive and non-invasive, what is the positivity rate?
No, madam. In PCPNDT also, there are two type of licenses there. One is the ultrasound monitoring, which is non-invasive. Another one is the invasive, where we are doing amniocentesis and CVS like that.
I am not aware of it. If you have the PCPNDT license, you can do anything. I'm not sure, Bhavani or Nisha, please answer his question. Do you
Sir,
need licenses?
Yeah, sir, you need to have a special license. You can, for a IVF lab, you have a license, but for doing
No,
genetic
he's
testing
saying
or
for
biopsy.
chronic villus sampling or a NIPT test or a amniocentesis. Do you need the same PCPNDT license or you need two different licenses?
No, you need to apply to them and they give you a different license, because this is all dealing with genetic. Now, even NIPT, they say that you have to be certified and you need to send the PCPNDT license of the lab where you are sending. So it has to be licensed, sir.
It
So
has
No, no, no.
anything.
That is
Madam, if
separate.
I may intervene, I'm Dr. Anupama Patil from Karnataka. We have to take invasive license in PCPNDT. The
Okay.
registration
Huh.
amount is also different.
Yes.
Okay, maybe you are
No,
right.
no, no.
Because, we
It is
already have these licenses, so we've never looked into this, that whether you need two licenses, like Dr. Mahapatra is asking, or just one license from the
Ma'am,
PCPNDT.
one license is there, but on that license, they take all the
Covers
options.
Okay.
invasive
Yeah.
covers both.
means
Dr.
when we
Mahapatra, you got your answer that you need a
huh,
second license for
yes,
invasive
madam. No,
methods.
no. What I want to know that yesterday with our ART board there was a discussion. There they are telling you are doing PGTA or PGTM or PGTA. It is also a sex detection procedure.
Yes,
If
yes.
yes, sir. So here where you got the license to do that PGTA like that. So
The
that is
ART,
my query.
you will get
To
the ART clinic
I have
license,
a ART2 clinic.
ART2 clinic plus the PCPNDT invasive license.
PCPNDT I have.
That's all. So both the
So
licenses are, we have got the ART license and we are now free to do whatever, but you have to fill all the forms, Form D.
all legal procedure I am doing.
Yes, yes, that you have to do, you will be safe. But you have to
Okay,
have both
madam.
the licenses.
Okay,
Ma'am,
madam.
may
Thank
I
you, madam.
add? Even the embryologist needs to be certified. Like for the
Yes.
iGenomics lab, only if the embryologist is certified by them, then only they can take the PGTA or PGT samples.
No, where it is
I'm
no
not sure
certificate.
about
It is
this.
no
No, it is
certificate.
true, ma'am.
It is
Shalini,
mentioned now.
iGenomics
Why
doesn't.
iGenomic lab?
Dr.
Why
Ma'am,
Shalini,
iGenomic lab?
yes, ma'am.
Others are
it's
also
the
doing, no?
it's the lab which the lab is certifying the embryologist.
Yes,
The PCPNDT
correct.
is not certifying.
Correct.
No.
PCPNDT, that is validation of the
My
embryologist, which is done
embryologist
by.
will be certified
Yes.
by the ART
Yes.
lab and by the PCPNDT.
Yes.
And iGenomics will separately be certified
Separately.
by the PCPNDT.
Ma'am,
No,
embryologist,
no,
the
is there like that
iGenomics
anything?
lab certifies. The embryologist also has to be certified by the
No.
From
iGenomics
where?
lab if we
No,
send the
we are
sample
not.
to their
We
lab.
don't have that. Anyone can take it who is already registered as an embryologist from my
Huh.
ART lab.
Okay, ma'am, I'll clarify, but
Just clarify
yeah.
and then put it
Yeah,
on the
we'll clarify.
there is
No,
something like
this
that, you all should know about it.
Yeah,
any
yes, ma'am.
embryologist
Agreed.
can do, I think, if they are officer registered embryologist.
Embryologist doesn't know to do embryo biopsy.
Maximum don't know, but there is no separate license. They need to do
Yes.
it, I think.
Yeah, I feel there is no separate license. We don't have any separate license. The embryologist, it depends how capable the embryologist is. Some cannot do ICSI, some cannot do a biopsy, some cannot do vitrification. So it is the efficiency of the embryologist. They don't need different license. Embryologist is supposed to do everything which comes under the gambit of embryology.
Ma'am, patient with just 2 or 3 biochemical pregnancies,
Mhm.
and maybe like suppose the age is 33 or 34. Do you
Mm.
advise karyotype or maybe those extensive tests,
I
whole
do.
exomes?
I do. If there are two failed implantations of good embryos, especially euploid embryos, two failed implantation, or maybe 3 embryos have failed to implant, or there are biochemical pregnancies, I like to do a karyotype of the parents.
So just the routine karyotype. You don't go
Routine
for
karyotype
those
of the
expensive
parents.
whole
Yeah.
exome
No,
sequencing
no, no,
and
no, 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 no,
no.
no, absolutely no. They write it for so many patients, and patients come with
Yeah,
80,000 bill of this whole exome sequence.
right.
Not all the younger genetist also once she wrote about for a patient of me, and
True.
I've just
That's why I'm asking,
I
ma'am,
said,
because I'm seeing a lot of prescriptions these days
coming.
coming with.
Yeah, ये जो
Yeah.
young genetist आए हैं ना, ये लोग लिखने लगे. I blew her up कि she's just had an abortion. You wrote a whole thrombophilia profile and whole genome sequencing, and
Sequencing.
you spend 80,000 on this, and
Hmm.
a thrombophilia profile will be inaccurate, because
Hmm.
wired one should be done after 12 weeks of in miscarriage.
In fact, these days, these geneticists, they are advising the carrier screen also, where they are screening the patients for the entire good number of.
No limit of investigations.
Yeah, true,
USA, they are doing it, and so it is coming to our country also.
true.
So I
And
think
do you Ma'am, do you advise PGTA to all? I mean, especially maybe
No,
should
no.
we be going to all PGTA to all patients above 40?
You see, in between, I'm just talking about what evidence said. It said it doesn't increase live birth rate and all. But there is a selective increase in live birth in women who are of age and whose aneuploidy rate could be higher. So depends on the number. If you've made only 2 blastocysts, क्या करोगे PGT में? तो भैया डालिए
Right.
अंदर, because इतना cost लगेगा, and then either it's euploid and it doesn't implant, or it is
Mhm.
aneuploid, so it miscarries or doesn't implant. But if there are 4-5 embryos, I would prefer to have a PGTA in women who are like 38, 39, 40. What is everybody's opinion? What is Dr. Shalini's opinion? What is Dr. Nisha's opinion?
Ma'am, I'm asking because I'm still not clear. I mean, should we be guiding, advising all the
I
patients?
feel if the number of embryos are good,
Yeah.
then it is a good option to have for women who are plus minus 42 years, matlab
Yeah,
38.
even, yeah,
Yukti,
I think
what
I'll
is
agree
your
with this.
opinion?
Yeah.
Yukti, what do you think?
Good evening, ma'am. Ma'am, there is a very high risk of aneuploidy in after 35 or even after 40 years. So definitely we should counsel them for PGTA.
Mm. Dr. Sunita Naik, what is your opinion?
Ma'am, I would like to not to do PGTA for all the patients because it
Correct.
might increase the cost, but the ultimately the cumulative live birth rate is the same. So rather
Yeah,
than transferring
cumulative
all
life
the
rate
embryos,
is the same. So a thought came in that don't do PGTA. But then in a selective group of patients where you think that they can't afford repeated IVF and you have 4-5 embryos and the woman is 40 years, I think it would be a good option.
okay,
Madam,
ma'am.
about
Okay.
NICS and PGTA, what you prefer, madam?
Amongst?
About NICS and PGTA, usually what you prefer?
NICS,
Non-invasive.
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 Oh, not non-invasive at all right now,
Right
because
now.
concordance rate is very low, especially of spent culture media. If you take
Hmm.
blastocele fluid, the concordance rate is extremely low. Of spent culture media also, it's 30-40%. So at the moment, we don't recommend non-invasive PGTA. We're
Okay.
doing invasive by cell biopsy.
Okay, I have a special request as a IFS secretary, madam. Can I call you anytime or message you? I have
Yes,
a
sure.
special
You can
request.
message me anytime. I would be very
Okay,
happy, Dr. Mahapatra.
okay, madam. I have a special request for my annual conference. So can I message you?
Sure, sure, sure.
Okay,
Sure.
madam. Thank you, madam.
Any other questions? I see lots
Ma'am,
of very learned people on this mm,
Forum.
screen forum, and I would want anyone's opinion on anything which you all think. I want the general obstetricians to understand that they have the biggest bank of patients who need to be referred for PGTM, especially, or maybe PGT-SR. So karyotype general obstetrician को कराना है after 2 repeated miscarriages first trimester. My message to all general obstetrician is 2 miscarriages in a row. Please do a karyotype. Maybe 2% will only have a translocation. 98% will be normal. But that cost is much lower than the patient going through multiple abortions one after the other. So that is one advice or one thing I would want to recommend. Another is if they come with an affected child of any type, please send them to the genetist to find out what is the reason for their problem. And if it is identified as a monogenic disorder, you can counsel them, especially if they can afford to go through IVF and PGTM. If they can't afford, then every pregnancy should undergo invasive prenatal diagnostic testing.
Madam, in biochemical, two biochemical pregnancy also better to do karyotype.
Yes, yes, we always do in repeated RIF cases, in biochemical pregnancies, miscarriages. Any other thing, Bhavani, comes to your mind, which I'm leaving out?
yes, ma'am,
Then,
and clinical pregnancy losses also, biochemical and clinical both.
RPL, RIF,
Yeah.
and biochemical pregnancies
Yes.
also.
Okay, thank you, madam.
Okay, thank you very much.
Madam, one question, ma'am.
Yes, who's that?
Uh,
Identify
yeah,
yourself.
I'm Dr. Anupama from Karnataka, ma'am.
Yeah, Anupam.
If there is a missed abortion repeatedly, how
Hmm.
will you differentiate whether it was an immunological loss or a genetic loss?
Anupama, a loss is always a loss. How do you know? Nobody does microarray testing on all the aborters. You cannot know if it is a genetic loss, whether the body has rejected or the embryo was not fit to grow. This is not at the moment a question of debate. If you've done microarray, okay, it is only to convince yourself and the patient that there was nothing wrong in the embryo and the chromosomal number was okay. Further than that, you don't know anything. So a karyotype becomes an important diagnostic modality. In UK, it is after 3 losses, but in rest of the Europe, USA and India, we do this test after 2 losses. There are only 3 tests which I do in patients who come with recurrent pregnancy loss by whichever nature it may have happened. One is karyotype of both the partners. Two is if these are early losses in the first trimester, then a APLA after 12 weeks of the last abortion. And APLA should have the lupus anticoagulant tested, anticardiolipin antibody, and beta 2 glycoprotein 1 tested. So all these 3 tests must be done. And the third one is a good 3D scan of the uterus to rule out septate uterus or any Mullerian abnormality, or in cases DNC has been done in the previous abortions, also to rule out a synechia. And I always like to do this scan in a patient who's ovulating regularly and have a 28-30 day cycle. Do it on the day 14 or 15 when the endometrium should be nice, plush and thick. So you'll rule out a synechia best at that time. Mullerian anomaly you can rule out at any time, but synechia, no. And if you're doing it for repeated miscarriages where a DNC has been done, very important to do these 3 tests for all patients. Besides, you will look for thyroid, diabetes, hemoglobin A1C, and whatever other test is in your armamentarium. I do these 3 tests generally.
And do you include antithrombin 3 also? Like you said, beta
No,
2 glycoprotein? No.
no, beta 2 glycoprotein is a acquired thrombophilia.
Right.
Antithrombin 3 is a hereditary part of hereditary. You see, hereditary thrombophilia has
Right.
3 protein deficiencies and 3
Mm.
gene mutations. Protein
Mm.
deficiency S,
ES.
antithrombin 3. Mutations
Okay.
are factor 5 Leiden mutation,
And
prothrombin
homocysteine.
20120A mutation, and MTFHR gene mutation. So
Right.
these, if any of this is low. High
Mm.
doesn't make a difference. If these are low, then these patients will need anticoagulant to support their pregnancy, because thrombosis is the reason where the blood supply is cut off for the baby and IUGR sets in and we have pregnancy losses. We don't do hereditary thrombophilia profile if the pregnancy loss occurs by 8-9 weeks with the cardiac or without a cardiac activity. But if it occurs at 12 weeks and
Yeah,
there is
mid-trimester.
of IUGR, yeah, then in those cases it is, if mid-trimester loss is due to PROM and
Mm.
the baby was normally growing before that, you don't need to do a hereditary thrombophilia profile. Only a acquired one is done where
Yeah.
lupus, ACA, and anti-beta 2 glycoprotein are there. Just 3 things.
Noted, ma'am. Thanks.
Madam, if APLA is positive, will you start low molecular weight heparin from the start of the ET cycle, ma'am?
No, as soon as beta HCG is positive. You know what? Whose question is this?
Dr. Anupama, ma'am, from Karnataka.
Anupama, it's very interesting. When I used to read it, you always used to be that you started from the cardiac activity. But we found in practical practice it doesn't work. So we started with the beta HCG positive aspirin and heparin. We start with the beta HCG positive time, not and the time of ET. So APLA could be positive for non-IVF pregnancies also with general obstetricians. Fine. Please do a proper lupus anticoagulant testing. See that they've written lupus anticoagulant was not seen. Lupus anticoagulant again has 3 components. Kaolin, KCT, kaolin clotting test. Then it has
DVVRT.
test, and it has a APTT test. Out of
Hmm.
this, The DVVRT is very important and the APTT is very important. One can leave the KCT test, and if any one of the two or both are positive, then lupus is present. And here, anticoagulation with aspirin or without aspirin, depending on whatever, is important as soon as beta HCG is positive in patients going through IVF or non-IVF spontaneous pregnancies, both. Nitisha, any question you have? Nitisha?
No, ma'am, it was a good class.
So I think we are all like, we do have question marks still on a lot of things. This is a new
And
procedure.
there are some questions which have been posted. Should I
Okay.
take them?
Yeah, I can't see the chat box. Okay. Now I can.
Ma'am, there's a
Yeah, there are.
question by Dr. Jhansi. Ma'am, can you tell regarding mito score?
Mito score is, I think someone else will talk about mito score. The higher it is, the poorer it is, the lower it is better. Probably it
Yes,
tells
ma'am.
you about the mutation in the mitochondria, the gene, whether it is homoplasmic or it is heteroplasmic. Am I right?
Ma'am, yes, ma'am. Usually with the PGTA report, they give the mito score also.
Yes.
Basically, it tells about the mitochondrial DNA content in the embryo. So the
Yes.
higher the mito score, the lower is the implantation potential of the embryo.
So,
But
what
there is
is this
still not
mito
much
score?
robust evidence on the use of mito score to decide which embryo to
Now, I'll tell
select.
you something
Answer
very,
it,
very
ma'am. Can
nice.
I
I
answer
told
it,
you
ma'am?
about the mitochondrial DNA.
Can
Now,
I answer it, ma'am?
yes.
Ma'am, as far as I had read, the activity of the embryo they study, it's a weak embryo, that is, if it's the potential of the embryo is low, then the mitotic activity to produce ATP increases. So the
Okay.
mitoscore will be more. The DNA content will be more. So DNA content more means a poor quality embryo.
Is this Anupama again?
Yes, ma'am.
So what you do is put it on the forum. What Bhavani is saying, she will find evidence to it and put it on the forum. What you are saying, you find evidence to it and put it on the forum. Let everyone read that why high mitoscore is poor and why a low mitoscore is considered good. Okay.
Yes, ma'am.
Ma'am, another question is by Dr. Sunita Nayak. What is pre-PGTM?
What is?
Pre-PGTM.
What is pre-PGTM means?
Ma'am, I think the
The
workup they do for
pre-PGT workup she wants to know
Workup.
about.
Yeah, it is like if there is affected child, you will test that child. Then you will test the parents from where it has gone. Like for polycystic kidney disease, we've just had a very recent one. So there it is almost a lethal gene where a person doesn't live for beyond 35, 40 years. So people have to check everyone, whoever could be concerned.
they actually make the probes by taking the samples and
Yes.
find out the mutations, and then they check the specific mutation for that
Yes.
particular disorder.
Yeah.
And ma'am, another thing I want to add, the other reason for taking grandparent sibling sample is also to see the inheritance pattern. Sometimes some diseases have multiple inheritance patterns.
Yeah.
So that also is one reason why they take samples of siblings and grandparents.
Yes. And there is another question in Klinefelter syndrome, if diagnosed. See, in Klinefelter's, you should have the sperm of the male. And if it is not Klinefelter's mosaic, or it is like at the age when men come to you at 30, 35, generally we don't find sperms in them. If rarely you can find a sperm, then definitely if it is a boy, will carry the same. But if it is a girl, could be normal, right? If I'm not wrong, Bolo?
Yes, ma'am. PGTA is recommended as far as I know in these cases. If we obtain sperms from a Klinefelter's male for IVF, so PGTA should be done.
Like a Y chromosome
No,
mutation, every
PGTM
male
should
child
be
will
done,
have
ma'am.
the same. Huh.
For Klinefelter's, I think PGTM, because it's the extra chromosome, no?
Klinefelter's,
Ma'am, but M is for monogenic disorders. This
yeah,
is a chromosomal disorder.
yes,
So PGTA should be
right.
able to.
Yeah, it should be, in what happens in Klinefelter's, tell me, Shalini.
It's XYY, ma'am, extra Y chromosome.
Right.
Yeah, so right, ma'am. I think it's, yeah, then it should be PGTA. True.
It is always good to speak up, because a lot of things
Yeah,
just get stuck in your mind. And when you speak it out, you come to the right answer, Khatse.
yeah, true,
We
ma'am.
all know the right answers, but
Yeah,
as time passes, it just gets all
mhm,
mixed up in the brain.
true.
Chal, I think we had a good discussion, and I'm very happy about the active discussion. I would want everybody to give their inputs. It makes me extremely happy to see that, you are listening and you have questions. So thank you again, and
Thank
I
you
would
so
thank
much, ma'am.
Intas. I would thank Intas for again, giving us this platform to be able to speak and helping us out with this educational endeavor, which I am taking, but I am only taking it because you all join me. If you all don't join me, the day I find that the number is going down, I will stop taking the classes.
No, ma'am, not the number, just the discussion.
Discussion is
Yeah,
very important.
true.
Numbers are also important, because it
True.
takes a lot of effort for
Hmm.
you to join in, leaving all your work, and for me to, make this presentation. It takes me like a week to sort of make it understandable. All right,
Yes.
good night,
Yes, ma'am. Have a good day. Bye bye.
everybody. Have a good day,
Yeah.
and thank you, Intas.